All right, future clinicians, welcome to a high-yield review of one of the most common issues you'll ever see in your practice, anemia. Today, we're going to walk through the entire clinical pathway, from a patient's first complaint all the way to their recovery. Let's dive right in.
First things first, why should this be at the top of your radar? Well, look at this staggering statistic. In places like India, where anemia is incredibly common, 1 in 5 women who die during childbirth die because of anemia. This isn't just a number on a lab report. It's a global health crisis with life or death consequences. And it all comes down to this little guy, the erythrocyte, or red blood cell. Its main job, its whole purpose, really, is to ferry oxygen from your lungs to every single tissue in your body. So you can think of anemia as a fundamental breakdown in this critical oxygen delivery service. So what is anemia, officially? It's when you see a drop in one of 3 key things: your total red blood cell count, the amount of hemoglobin inside those cells, or your hematocrit, which is just the percentage of your blood made up of red cells. No matter which one drops, the end result is the same. Your blood just can't carry enough oxygen to meet your body's needs. So here's our game plan for today. We're going to follow the exact path you take with a real patient. We'll start with their story, then decode the lab results, figure out how to classify the anemia, and finally put together a solid treatment plan, a nice logical flow. Every single diagnosis starts with the person sitting in front of you. Long before you order a single test, the patient's own story and the symptoms they describe are giving you your very first clues. Now, a patient with anemia is probably going to tell you they feel exhausted, that their heart pounds in their chest, or that they get short of breath just walking upstairs. They might have trouble concentrating or feel dizzy. None of these are specific to anemia, but when you see them all together, it paints a classic picture of a body that's starved for oxygen, and anemia should jump to the top of your list. This is where taking a detailed history is so crucial, because some symptoms can point you to a specific cause. If your patient mentions they've been craving and chewing on ice, that's called pica, and it's a bizarre but classic sign of iron deficiency. On the other hand, if they complain about a pins and needles feeling in their hands or feet, your brain should immediately be thinking about a vitamin B12 deficiency. See? The clues are right there in their story. Okay, so you've listened to the patient, you've got your suspicions. Now it's time to get some objective data to back it up. And for that, we turn to the complete blood count, the CBC. This is where we get the hard numbers. The first 2 values you'll look at are hemoglobin and hematocrit. Hemoglobin is the actual protein carrying the oxygen, and hematocrit is the portion of blood made of red cells. Now, what's normal depends on who your patient is. You can see the ranges are different for men, women, and especially for pregnant women. If their numbers fall below these thresholds, you've officially confirmed they have anemia. But knowing that they have anemia isn't enough, right? We need to know what kind. This is where the MCV comes in, and it is absolutely critical. It tells you the average size of the red blood cells. Are they too small, microcytic, too big, macrocytic, or just right, normocytic? This one number is probably the most important fork in the diagnostic road. Next up is the MCH. This tells you the average weight of hemoglobin in each red blood cell. To be honest, this number usually just follows the MCV. It makes sense, right? If you have a tiny little cell, it's probably going to have less hemoglobin in it by mass. And finally, we have the MCHC. Now this one is a little different. It tells you about the concentration of hemoglobin. Think of it this way. If MCV is about size, MCHC is about color. A low MCHC means the cells look pale, what we call hypochromic. A normal MCHC means they have a normal color, or normochromic. Okay, this is where it all comes together. We have the cell's size from the MCV, and we have its color from the MCHC. We're now going to combine these 2 pieces of information to classify the anemia based on how the cells physically look, their morphology. This is where the diagnosis really starts to take shape. This table is your roadmap. It's so powerful. If the lab report comes back and you see a low MCHC and a low MCV, what does that mean? It means you have small, pale cells, hypochromic, microcytic, and your brain should immediately jump to iron deficiency or thalassemia. What if the MCHC is normal, but the MCV is high? Well, you've got large cells with normal color, normochromic, macrocytic. That screams vitamin B12 or folate deficiency. This approach is the cornerstone of your workup. So let's quickly talk about the why behind these different looks. Iron deficiency is basically a supply chain problem. You're either not getting enough iron in or you're losing too much, which is very common in women because of menstruation or pregnancy.
Without enough iron bricks to build hemoglobin, the cells just end up small and pale. Megaloblastic anemia, on the other hand, is more of a factory problem. Without B12 or folate, the bone marrow can't produce DNA correctly, so it churns out these big, weird, dysfunctional cells.
So, you've cracked the case. You've figured out the type and the cause. Now, for the final, most important step, creating a management plan. And the goal here isn't just to fix the lab numbers. It's to get the patient healthy and make sure this doesn't happen again. Your treatment plan should have 3 clear goals. Number 1, find and treat the root cause. Don't just hand out iron pills. Figure out why they're iron deficient in the first place. Number 2, the treatment itself aims to get their hemoglobin back to normal, but also, and this is key, to refill their body's iron savings account. And number 3, you have to empower the patient with advice on diet and lifestyle.
And that patient counseling is a huge deal. You can give them simple, powerful tips, like tell them to take their iron supplement with a glass of orange juice because vitamin C dramatically boosts absorption, and tell them not to drink coffee or tea with their meals since those drinks block iron absorption. These little changes can make a massive difference. It's also really important to manage expectations. For a common iron deficiency, you can confidently tell your patient that with the right treatment, they should see their anemia corrected in about 2 to 4 months. You'll also want to explain that they'll need to stay on the supplements a bit longer to fully build back up their iron stores. And the payoff for getting this right, it's enormous. We're not just talking about a patient who feels less tired. For kids and teenagers, treating anemia is directly linked to better cognitive development. We're talking about brain function. For pregnant women, it lowers the risk of having a low birth weight baby and reduces their own risk of dying. For everyone, it means better fitness, better performance at work, and a sharper mind. So we have the knowledge to diagnose it and effective treatments to fix it. That leaves us with one final and really important question to think about as you go forward in your careers. If the clinical part is often pretty straightforward, what are the bigger barriers? Things like access to care, education, and nutrition that are keeping anemia as this massive, persistent global health crisis.